Hello everyone. Today we'll discuss about approach to paraparesis. That is whenever an individual presents with lower limb weakness. So how to proceed in neurology. Mainly we'll focus on myelopathy in the further lecture. So first, what happens in majority of the cases, the individual will complain of lower limb weakness, which will be in the form of difficulty in getting up or difficulty in walking, buckling, gripping the slippers, etc. But most of the times there will be associated sensory symptoms, which we will not be able to specify to whether it is due to peripheral nerve or due to spinal cord lesion. So this will be the most common situation we will be stuck in, whether it is because of cord lesion or because of the peripheral nerve. So we will discuss it and we will go through the approach proper. First thing will be, we have to decide based on the history whether the weakness, whatever he is complaining, is because of UMN lesion or LMN lesion. Why is it important? As we all know, cord, anything related to cord will be UMN. So spinal cord, whereas element type of weakness will be because of peripheral nerve. So we will be focusing on these two mainly. There are numerous causes for element type of weakness. For example, muscle diseases, neuromuscular junction disorders, anterior horn cell, radiculopathies, and peripheral nerves. But we will be in confusion whether the disease is because of the cord or peripheral nerve, when especially the individual is presenting both motor and some non-specific sensory symptoms. So how to differentiate the weakness as UMN or LMN? See, in UMN type of lesions, when they complain about the weakness, most of the times they will say it as heaviness of the limb or stiffness. So this we have to focus in case of UMN lesion. And next one is, in UMN type of lesion, group of muscles will be involved, or sometimes the entire limb might be involved, compared to the LMN where only specific muscle will be involved majority of the times. So here group of muscles involvement will be there, and all the UMN lesions will start distally. Like distal weakness will be predominant, then it will progress to proximal muscles, whereas LMN lesion will involve proximal group of muscles. Only exception for this is which will start distally and progress proximally. Exception is GBS. So this is the exception. Whereas in UMN lesion, as I told, it will start distally. So this history is important. Distal, then proximal. So when we are taking history, we have to focus on these things to differentiate whether the lesion is UMN or LMN. So this is the first thing. So second question in the approach is, what are the hallmark features of spinal cord disease? So we have to know, if we are thinking in terms of spinal cord disease, we have to search for the hallmark features. Those are, first thing will be, a definite level will be there in case of spinal cord lesions. So definite level. So below this level, all three components will be affected: motor, sensory, and autonomic. So what we'll see below this level of lesion, usually in motor there will be either paraparesis or quadriparesis or quadriplegia also, but this will be UMN type. Whereas sensory, there will be complete loss of sensation below that level. So loss of sensation will be there. In autonomic dysfunction, there will be undue sweating or bowel bladder dysfunction, then erectile dysfunction. So these features will be there. And at the level of lesion, in motor we can see atrophy and areflexia at that level. And in sensory, at the level of lesion, we might see hyperalgesia, involvement of spinothalamic tract, whereas other feature might be hyperesthesia, again suggestive of posterior column involvement. This will be at the level of lesion. So we have to look for this. Then what are the other hallmarks? Bowel bladder involvement, as I told here, bowel bladder dysfunction will be in favor of cord lesion majority of the times. Then other things are extensor plantar reflex. So this will be again in favor of cord or UMN lesion. So we have to search for these things so that we will be sure enough that it is definitely cord lesion. This is question number 2. So the next question is about the timing, that is temporal evolution we have to observe. So we have to assess the duration of the symptoms which patient is complaining. So based on that, especially in case of spinal cord lesion, we will divide it into acute and subacute duration, or is it chronic. Again, in both we will divide it into whether it is compressive or non-compressive. Again, in chronic, compressive or non-compressive. So how to differentiate compressive versus non-compressive first? In compressive type of lesions, usually there will be antecedent symptoms. For example, neck pain. So neck pain or back pain, or sometimes sensory disturbances, sensory lesions, sensory disturbances, even sometimes bladder dysfunction. After that, after some time, they will develop weakness, that is paraparesis, or motor involvement will be seen later. So some antecedent symptoms will be there, whereas in non-compressive type of cord lesions, there will be direct weakness will be there, no antecedent symptoms. So this one we have to decide first whether it is compressive or non-compressive type of lesion. Then we can decide what might be the reason for acute and subacute and chronic. And in neurology, as we know, acute is anything which is less than 4 weeks. Subacute is 4 to 8 weeks, whereas chronic is more than 8 weeks. Again, in acute, sometimes there will be, the onset will be sudden. So in such cases, we have to think of either vascular etiology or in inflammation, mainly demyelination. So for sudden onset disorders in neurology, consider vascular or demyelination, and that will come in acute. Whereas subacute, most of the times it will be either infectious or para-infectious, any autoimmune diseases, or nutritional or space occupying lesions. So this much we have to remember. Whereas in chronic, like hereditary disorders or degenerative, mainly degenerative lesions, and again some space occupying lesions which will progress and present late. So these things have to be kept in mind when we are dealing any case of neurology. Now we will discuss the causes. So sudden onset, for example, acute onset less than 4 weeks with antecedent symptoms of compression. So what might be the reason? We have to remember tumors, especially metastasis to thoracic spine, then any abscess or hematoma. So this is acute onset compressive cord lesions reasons. Coming to the non-compressive, like no antecedent symptoms, but it has started acute or subacute duration. So here comes mainly infarction, then some inflammatory diseases such as demyelination, which will be non-compressive, and some infectious, especially viruses, and some para-infectious, infectious and para-infectious we can consider para-infectious, and these will be mainly subacute in duration. Then some autoimmune diseases, especially SLE, systemic sclerosis or Sjogren's, then sarcoidosis. So these are some reasons for non-compressive acute to subacute type of spinal cord diseases, and we have to know few points about each when we are considering these possibilities. See, in infarction, mainly we know that it is anterior spinal artery and posterior spinal artery. So for the paraparesis, it is mainly anterior spinal artery infarction, and as we know, it is very rare to involve both sides of anterior spinal artery, and sometimes we add an adjective, that is unpaired anterior spinal artery infarction. So that is also very rare to see. And we have to know one thing, that in case of anterior spinal artery involvement, like the territory will be majoritarily, it will be anterior part of the cord. So posterior column features will not be seen. And if you are suspecting posterior spinal artery infarction, again the anterior part will be spared. So the spinothalamic tract features will not be there. So that one we have to keep it in mind. Coming to demyelination, mainly here we will consider MS, multiple sclerosis and NMO. Mainly multiple sclerosis and NMO, neuromyelitis optica and the NMO spectrum disorders. Here the thing is, as we know about MS, it can involve many parts of the nervous system, like it will be distributed in time and space. Majority of the times it will be relapsing remitting pattern, and cerebellum, sensory, optic nerve, motor and sensory things might be involved in MS. And there might be history of improvement with steroids and all. So it will be relapsing remitting pattern. NMO is a rapidly spreading disease. It will involve more than 3 vertebral columns, and optic neuritis usually it will be associated. So for these, what we have to do, like we will consider CSF analysis and oligoclonal bands and some autoantibodies like aquaporin 4, etc. And coming to the infectious and para-infectious, here important history will be like preceding fever, myalgia or some typical infection will be there. After that they will develop weakness like cord involvement. Again, this is very rare. Coming to some autoimmune diseases, mainly sarcoid myelopathy and some systemic sclerosis or SLE kind of thing, those we can consider as the possibility. Those are very rare actually. So these are the things we have to think of when we are dealing with any case of lower limb weakness of less than 4 weeks or 4 to 8 weeks duration, acute to subacute. Coming to the chronic compressive and non-compressive cord lesions, here in compressive mainly we will consider spondylosis leading to spinal cord compression. So what will be the features? Usually it will be associated with, for example, if it is cervical, then neck pain will be there, which will radiate to the arms. So it will be radiating in nature, and this pain, this type of compressive pain will aggravate on any strenuous exercise, like strenuous activities, especially coughing. So aggravates on cough, and we will be able to see some tingling, numbness sensation at the hand, abnormal sensations of palms. Then there might be atrophy of hands, or at that particular level there might be atrophy also. So these are few features suggestive of spondylosis, and over a period it can lead to, like it can even involve bladder, but that will be very late. Whereas coming to the non-compressive chronic myelopathies, here we can remember it with the series of alphabets like B for B12 deficiency. We call it as subacute combined degeneration. C for copper deficiency. This can also present with the same as B12 deficiency, but here one important point is, whenever we are pointing at B12 deficiency as the cause, remember that majority of the times it can lead to peripheral neuropathy, but causing cord lesion is very rare due to B12 deficiency. That we have to keep it in mind. Then D for dorsalis, that is Tieb's dorsalis, secondary to syphilis. And whenever we think of syphilis, consider HIV associated myelopathy, which is also called as tropical spastic paraparesis, and HIV is ending with V. So next cause might be vascular malformations. So this will be like there will be claudication, intermittent type of weakness, and it will be slowly progressive in case of vascular malformations. And whenever there is term of malformation, think of hereditary. So next cause is hereditary chronic non-compressive myelopathies, and we will be able to see deformities in case of hereditary. And once hereditary word is there, it has to trigger some developmental abnormalities, that is developmental syringomyelia. So syringomyelia, it can be developmental as well as acquired, but just to remember, I am telling this pattern. And one more important thing is exposure to toxins, especially BOA toxin and nitrous oxide inhalation. So these might be the possibility. So we have to take the history related to these things whenever we are dealing with chronic non-compressive myelopathy. So these are few causes related to the timing. But related to the timing of weakness, I have seen students getting confused when there is intermittent weakness. So we have to remember one thing: whenever the patient complains of intermittent complaint, that is relapsing remitting type of weakness. So main causes we have to remember for intermittent weakness. Mainly, as we all know, it is MS. First thing which should come to our mind. Then for young individual, it can be periodic paralysis. Periodic paralysis. So here, as part of workup, we have to get thyroid profile, then history of diabetes, and any binge eating related weakness is very important in periodic paralysis. Then comes CIDP possibility and porphyrias. So associated abdominal pain history is important in porphyria. And GBS can also be possible, but very rare, like relapsing variant of GBS. So at least these things should be there in our mind whenever there is intermittent weakness. Next question is about the localization of the lesion. So we will deal it in two segments mainly. First one is we have to know the relationship of spinal cord and the vertebral bodies. So here usually, and these are the vertebrae. So the spinal nerves will come out like this, C1. So this will be C2, C1, C2, C3, like this. So at the cervical level, it will be 1 to 1. You can remember 1 to 1. And whenever there is a lesion in these cervical vertebrae, the highest number of nerve will be damaged. For example, if there is any lesion between C5 and C6 vertebrae, so the nerve which is involved will be C6, highest one. And as we come down, so C3, C4, C5, C6, then C7 here, and C8 nerve will come out here. So here is the change actually, because here there is no C8 vertebra obviously. So T1, above that C8 will emerge out, like that T1 here, like that it will go on. Now it has changed. So any lesion here, for example, like L5, L6, or as we are discussing here, thoracic, you can consider D5, D6 vertebral lesion. Then the nerve involved will be the lower one, that is D5, like this. So how to remember it easily? See, cervical vertebrae are at the top. So whoever is sitting at the top will get more score. Whoever is at the down will get the lesser number. So if I ask you if there is a lesion between L4, L5, so what nerve injury will be there? It will be L4. So the lower one we have to consider, like that. And one more important thing is lumbar segments of vertebral bodies. Here it will be group of nerves, mainly T10 to T12. So this one we have to remember, because majority of the times in the reports we will see like lumbar segments L4, L5, vertebral disc bulging and all. So it will lead to the lesion at the level of T10 and T12. So we have to focus mainly on the abdominal reflex loss. This is first point. Then in the lower limbs, mainly lower limbs, the supply will be L1, L2, L3, L4, all those nerves. So it is above that lesion. So obviously it will be UMN type of findings in the lower limbs. That is increased spasticity, plantar will be extensor, like that. So this is the relation of spinal cord with the vertebral bodies. This is first segment. Second one is some important clues related to the levels of nerves that we will discuss in the next thing. Second part of localization involves this one. For example, if there is upper cervical cord lesion, they will present with quadriplegia plus diaphragm will be involved. So breathing difficulty will be there, that is the clue. C5, C6, biceps reflex and its action will be affected. So this is the clue. C7 is mainly for triceps, action and reflex, then the extensor aspect of the upper limb. So mainly wrist extension we can consider. C8 is about wrist flexion and the hands. So mainly wrist flexion and the hands muscles will be affected. T4 we all know, nipple level. T10 is umbilicus. Then coming to L2 to L4, that is lumbar plexus. See, mainly why is it so much important? So it will mainly affect all the actions related to the upper part of the lower limb, that is thighs, mainly hip flexion, then knee extension and knee jerk will be affected, that is lost. Whereas L5S1, here ankle jerk will be lost and movements related with foot will be affected. So foot muscles, foot movements will be affected. At the end comes conus medullaris and cauda equina. So first we will deal with cauda equina. Here mainly like the radicals will be involved. So sharp pain will be there and lower limb weakness will be there. Lower limb weakness, but there will be sacral sparing. Whereas conus medullaris is the central part. So here bladder bowel involvement will be very early. Bladder bowel, and there will be erectile dysfunction also. But here lower limb muscle strength will be largely preserved. That we have to remember. No lower limb weakness. Whereas one more syndrome will come, that is epiconus syndrome. So that is lesion slightly above that. Here lower limb weakness will be seen in epiconus syndrome. So these are some clues which we have to remember when we are dealing with localization of the myelopathy. Finally, we have to see whether the symptoms or the complaints are fitting into any syndromes. We call them as spinal cord syndromes. So mainly remember about foramen magnum syndrome, then anterior cord syndrome. Here obviously the posterior column will be spared. Posterior column spared. That we have to keep it in mind. Central cord syndrome, I hope you all know about syringomyelia. So that will fit into this syndrome. Then hemicord, probably you have heard about Brown-Sequard syndrome. Brown-Sequard hemicord syndrome. And other important thing is intramedullary and extramedullary syndromes. So we have to decide where is the lesion exactly. Again, in intramedullary, there will be the pain will be poorly localized, dull type of pain. Whereas in extramedullary, it will be sharp pain. And here, intramedullary bladder involvement will be early. Here it will be late. But here, the motor weakness will be late feature. Late motor involvement. Here the corticospinal tract or like motor dysfunction will be early. Here we will see sacral sparing. Whereas in extramedullary, early sacral sensory loss, sacral involvement will be there. So this much we have to know. This is the overall approach to any patient who is presenting with lower limb weakness and particular focus on the spinal cord lesions, that is myelopathy. Thank you.